Welcome to the topic drugs for dysrhythmias. So dysrhythmia is nothing but the abnormalities of the electrical conduction or rhythm in the heart. They're also known as the arrhythmias, and the proper diagnosis and the optimal pharmacological treatment can reduce the frequency and consequences of the dysrhythmias. Some types of dysrhythmias produce no patient symptoms, whereas others may be life-threatening in this one. So the symptoms includes the dizziness, weakness, decreased exercise tolerance, shortness of breath, fainting, palpitations. And then the dysrhythmias, they're classified by their location and type of the rhythm abnormality produced. What are the types of dysrhythmias? Atrial or ventricular flutter or fibrillation. In this, it is very rapid, uncoordinated beats occurs. Atrial may require the treatment, but is not usually fatal. And the ventricle flutter or the fibrillation requires immediate treatment. Then atrial or ventricular tachycardia, rapid heartbeat greater than 100 beats per minute in adults. Ventricular tachycardia is more serious than the atrial tachycardia. Heart block is the area of non-conduction in the myocardium, may be partial or complete, classified as first, second, or third degree. Premature atrial or premature ventricular contractions, an extra beat, often originating from the source other than the SA node, not normally serious unless it occurs in the high frequency. Then sinus bradycardia is the slow heartbeat, less than 60 beats per minute, and it may require a pacemaker for that case. What are the diseases were commonly associated with the dysarrhythmias like hypertension, cardiac valve disease such as the mitral stenosis, coronary artery disease, medication such as the digoxin is the first choice of the drug here, low potassium levels in the blood, and the myocardial infarction, that is the stroke. Adverse effects from the antidysrhythmic medications also occurs, which is like for the stroke, diabetes mellitus, congestive heart failure. So if a person is having the dysarrhythmias, they have more chances of having these things. The electrical conduction pathway in the myocardium keeps the heart beating in the synchronized manner. Like the common factors are if there is a defect in the formation or the conduction of electrical impulses across the myocardium, or the lack of the synchronicity between the atria and the ventricles could lead to the serious consequences as well. Here we can see the normal conduction pathway in the heart. It starts from the SA node. This SA node is kind of a switch which triggers sinoatrial node. It goes down, it sends the stimulus down over here to the AV node, atrioventricular node. From here, it goes to the bundle of His, and from the bundle of His, it goes to the here into the right and left bundles, into the interventricular septum. It goes here in the Purkinje's fiber. And at the end, it goes to the here bundle of His is selling all this conduction. So common factor is when we do the ECG, that is the normal electrocardiogram tracing, what happened? We usually see this type of the graph, which is have a crest, a big crest, then troughs, then crests and troughs, and it's a wave-like appearance. So these are called as like this one, the first one. If you see the square, this is a P wave. It moves like this. If this is a wave like this is the P wave. It is actually doing when the atria is depolarizing and contracting in the heart. Then the P wave occurs. Then after that, when this wave is going down, which is called as the Q wave. After the Q, when it goes to the hike, it is called as the R. It comes down, it is called as S. So QRS, it becomes a one complex in which the ventricles are depolarizing and contracting. Then we get the T wave, in which the ventricles again repolarize and relax. So usually when the atria contract, that is P wave. When ventricles contract, this is QRS wave. And when the ventricles relax up after pumping the blood from the heart, that is the T wave. So that is in a graphical form, which is called as a normal electrocardiogram tracing. Most antidysrhythmic drugs, they act by blocking the ion channels in the myocardial cells. So these are the flow of the ions through the ion channels in the myocardial cells. So what happened again? In the first picture, we can see the resting state before action potential. So all the sodium ions, potassium ions, calcium ions, they are present outside, they are open, and the channel gates are closed. This is the gate which is closed on all the channels. Now, after the resting, the depolarization occurs and the sodium channel and the calcium channel, these gates are getting open and you can see the sodium can go in and the calcium can go in. After the depolarization will be done, these channels will be closed. Again, sodium and calcium, they both will be closed and the repolarization will occur in which the potassium channels from the inner side will open and the potassium will start moving from the in to the outside. After that, again, that channel will be closed, which is again, we can set that as the return to the resting state, all channel gates closed. So this is how sodium, potassium, and calcium channels, they're opening, taking, and going in and out, depolarization, repolarization, and the resting potentials. That's how the ions flow into the myocardial cells. Then we have antidysrhythmic drugs, which are classified by their mechanism of action. What are the categories of the antidysrhythmics? Number one, sodium channel blockers. We just saw in the picture, sodium channel, which are going to block the sodium channels. They are sodium channel blockers. Which block the beta blockers? They are beta-adrenergic blockers, potassium channel blockers, calcium channel blockers, and miscellaneous antidysrhythmic drugs. So we have to remember, class 1 will always be sodium, 2 will always be beta, 3 is potassium, and 4 is always calcium. Now let's talk about in this little detail, sodium channel blockers. They slow the rate of impulse conduction through the heart. That's how they work. So sodium channel blockers, they're the largest group of the antidysrhythmics. They have the 3 subgroups, 1A, 1B, and 1C. They are based on subtle differences in their mechanism of actions. The example becomes lidocaine. It is also used as an anesthetic drug. Then the sodium channel blockers, because the progression of the action potential depends on the opening of the sodium ion channels, the blockade of these channels will slow the spread of impulse conduction across the heart or the myocardium wall. All dysrhythmics, they have the potential to cause the new dysrhythmias. Frequent ECG monitoring is recommended. Then is the beta-adrenergic blockers. They reduce the automaticity and they slow the conduction velocity in the heart. They have the ability to slow the heart rate and the conduction velocity, and they can suppress several types of dysrhythmia. It's a very good drug, and their basic actions include they slow the heart rate, they decrease the conduction velocity through the AV node. Then also, the beta blockers, they reduces the myocardial atomicity, and the many types of the dysrhythmias are being stabilized by this drug. Main value is to treat the atrial dysrhythmias associated with heart failure, not with the ventricles. So beta blockers are only used for the atrial dysrhythmias. Then we have the potassium channel blockers. What they do, they prolong the refractory period of the heart. They block the potassium channels in the myocardial cells. They prolong the duration of the action potential by lengthening the refractory period, like putting them into the resting stage. Then they stabilize the dysrhythmias in this way. The adverse effect of this is, it is very potentially serious adverse effect. It causes bradycardia, that is slow heart rate, and hypotension, low BP. It also worsens the dysrhythmias. Then comes to calcium channel blockers. They are available to treat the supraventricular dysrhythmias. They slow the conduction velocity, they stabilize certain dysrhythmias. Not all the calcium channel blockers can treat those dysrhythmias, only few can do that, and only effective against the supraventricular. So these ones, they are not effective against atrial. So atrial, like beta blockers, they don't act upon the ventricles. Their effect includes they reduce the atomicity in the SA node, they slowed the impulse conduction through the AV node, they prolong the refractory period, they stabilize many types of supraventricular dysrhythmias. Then we have the miscellaneous drugs like digoxin, adenosine. They are used for specific dysrhythmias but do not act by blocking the ion channels. So adenosine is given as 1 to 2 second bolus IV injection, and their actions, they terminate the serious atrial tachycardia, they slows the conduction through the AV node, and they decreases the atomicity of the SA node. Other than that, the primary indication of the adenosine is they're used for paroxysmal supraventricular tachycardia, for which it is a drug of choice, PSVT, 10-second half-life only, and the adverse effects are generally very self-limiting. Then is the digoxin. Digoxin is primarily used to treat the heart failure, but it is prescribed for certain types of atrial dysrhythmias as well. They decreases the atomicity of the SA node and this slows the conduction through the AV node as well. So the key drugs that we all studied, beta blockers for atrial, acebutolol, atenolol, metoprolol, propranolol. Calcium channel blockers, diltiazem, verapamil. Cardiac glycoside is digoxin. Potassium channel blockers is amiodarone and dipetylide. Dronidarone, ibutylide, sotalol. Sodium channel blockers are the flecainide, lidocaine, mexolitine, procainamide, propafenone, quinidine sulfate. Then in the nutshell, in the summary, dysrhythmias, they classified according to their location and abnormality producers. They can be asymptomatic, they can be life-threatening. Cardiac electrical conduction keeps the heart beating in this one. So antidysrhythmic drugs, they block the ion channels, and that also how they are classified. Sodium channels, potassium channels, and beta blockers, calcium blockers. Digoxin and adenosine we study, we do not block the ion channels, but they are also acting as in dysrhythmic drugs. And these agents, they slow the conduction as well. Thanks for watching the video.